belatacept has despite this, belatacept has demonstrated non-inferior patient and graft survival, which led to that FDA approval specifically in combination with non-depleting agents. So more recently, more and more transplant centers have started exploring its use alongside with depleting agents such as thymoglobulin to better address that early rejection risk. Next. So given this connection between belatacept and that increased risk of rejection, the question really becomes, can we improve the outcomes by optimizing those induction regimens? There's a clear gap in literature where it comes to when it comes to comparing thymoglobulin regimens in context with belatacept. So our study will aim to fill up those gaps by evaluating how different thymoglobulin dosing strategies may impact that rejection and other clinical outcomes. Next. So what we did was a retrospective chart review. It was a total of 361 adult kidney transplant recipients that were included, and that was from March 2018 to December 2023. Next. Here I included the inclusion criteria, so they were all kidney transplant recipients and they were all from deceased donors and were patients that were started on that de novo belatacept. And I just have included here as well the exclusion criteria more for your information. Next. Our outcomes, these were analyzed over 6 months post-transplant. We were primarily looking at biopsy-proven acute rejection, and for secondary outcomes included antibody-mediated rejection, the incidence of viral infections such as cytomegalovirus, BK, and adenovirus, and we also looked at graft and patient survival. Next. These are some data collection points that I just collected for the data analysis, but this is as well for your information for time's sake. Next. All right, so in the next portion of the presentation, I'll share the outcomes of our analysis, and just to maintain the consistency and account of for the institutional protocols changes over time, we categorize these groups from group A to group E, depending on the specific time period and the induction regimens that these patients were using. So for instance, we will look at group A that was back in 2018, where we were using thymoglobulin 1 milligram per kilogram plus a dose of basiliximab. And then after that, group B and group C will account for thymoglobulin 3 milligrams per kilogram plus or minus basiliximab. And more recently, we've been using higher doses of thymoglobulin with 4.5 milligram per kilogram plus or minus the basiliximab. So this is how we're going to see those results shown in the next few slides. Next. Right, starting with the results, with the baseline characteristics, as we can see, they were pretty similar across the groups. We had an average age of 58.39 across the groups, where most of the patients were male gender with 74.5%. And as we can see, most of them were Hispanic with 39.6%, followed by Black patients with 37.4%. Next. As we can see in this table, more baseline characteristics, most of our patients were considered low immunologic risk with CPRA less than 40%, which that accounted for 98.1% across the groups, and 67.9% were considered delayed graft function, meaning that they needed that hemodialysis within 7 days post-transplant. Next. So starting with our primary outcome for biopsy-proven acute rejection, we can see that the majority of the patients that experienced this were in group A with 36.2%. Although this group had the highest incidence, as when we compare it to the other groups, there was no statistically significance. Now I do want to focus on group D and group E, where I just want to remind you that these groups were the ones that had the highest doses of thymoglobulin with 4.5 milligram per kilogram, plus or minus a dose of basiliximab. So as we can see, there was not many differences in these groups, even though one received more induction or more immunosuppression than the other. So more immunosuppression didn't make a difference. Next. And this was the p-value. Sorry. All right, so for antibody-mediated rejection, something very similar to our previous outcome, we see the majority that occur in group A, which, just reminding you again, group A was that group with the lowest dose of thymoglobulin. It was 1 milligram per kilogram with a dose of basiliximab, but when we compare it to the other groups, it was not statistically significant. Next. Now for infections, I want to highlight specifically cytomegalovirus infections, which is the darker blue. We can see that the highest incidence was seen in group D with 25.5%. And when we compare this to the other groups, it was statistically significant. Now, in this group D, this was a dose of 4.5 milligram per kilogram with no basiliximab. So this tells us the higher the immunosuppression, the higher the infection risk. Now, when it comes to BK and adenovirus, we did not see any differences across the groups. Next. And finally, for patient and graft survival, just making sure in the x-axis we have counts, so not percentages, but as we can see, regardless of what type of immunosuppression that they were receiving, what induction regimen they were receiving, we can see that for patient and graft survival, so we had greater than 90% graft and patient survival, which was a great outcome. And it was not statistically significant across the groups. Next. So as a conclusion, as we can see, lower doses of thymoglobulin exhibited the highest incidence of biopsy-proven acute rejection, while on the other side, the higher the doses of the thymoglobulin was associated with higher risk of CNV infection rates. Now, belatacept may offer reliable long-term outcomes across different dosing strategies, as we saw in patient and graft survival that was greater than 90% across all the groups. But there is future research that we will need to ensure balanced groups distribution just to enhance the accuracy and reliability of the outcomes assessments. And then just finally, as your information, we're still working on additional statistical analysis just to validate our results and expand on some of them as well. Next. And these are my references. And any questions will be welcome. Thank you.
Thank you so much. Reminder, if you have any questions, please place those in the Q&A section that is available on Zoom, and we will answer those at the end of all of the presentations. And thank you so much again for your great presentation. We will move on to our next speaker.
Thanks.
Okay. Hi, everyone. My name's Nick. I'm the current PGY2 solid organ transplant pharmacy resident at VCU Health. And today I'll be discussing my research project titled Comparison of Belatacept versus Tacrolimus in Elderly Kidney Transplant Recipients. Next slide. Just to start off with a brief overview on belatacept and the existing literature. Next slide. So I won't go into much detail about this, but as was already mentioned, belatacept is our novel co-stimulatory inhibitor, kind of two dosing strategies that exist out there, de novo versus conversion. An adverse effects for us to be aware of, potential increased risk of infection, as well as increased risk of post-transplant lymphoproliferative disorder, especially using it in our EBV naive patients. However, belatacept does offer some potential advantages, such as preserving renal allograft function and improving long-term outcomes. Next slide. So as we know, with our elderly transplant recipients, they have less robust immune systems compared to our younger transplant recipients. So there's been kind of discussion out there on how do we balance immunosuppression in these patients while also managing toxicity. The current literature within this patient population is limited. There was an ATC abstract that I found that looked at belatacept conversion specifically in our elderly renal transplant recipients. They also defined this as greater than or equal to 60 years old. Primary objective, looking at 6 months incidence of infection and malignancy. Also looking at renal function, incidence of rejection, graft loss, and death. What they found was primary reason for discontinuation was rejection followed by infection, where 39% of patients experienced at least one infection within 6 months of conversion. But they did notice these patients had improved eGFR and rejection incidence was about 20%. Next slide. So current practice here at VCU, we utilize conversion dosing with our belatacept being dosed as 5 mg per kg IV every 2 weeks for the first 5 doses, then transitioning to 5 mg per kg IV every month. Tacrolimus is weaned over the first 4 to 6 belatacept doses. Next slide. So the need for this study, as I mentioned, meaningful clinical trials evaluating the use of belatacept in elderly patients are currently lacking. Outcomes, particularly related to infection, are not well defined, and this study will better allow us to understand belatacept use within this patient population at VCU specifically. Next slide. Moving into my methods. Next slide. This was a single center retrospective cohort study. Our study period was from December 2021 to August 2023. Study population had 64 patients. Data collection was through secure electronic health record chart review, and then data analysis consisted of descriptive statistics and chi-square testing. Next slide. For study objectives, our primary objective was again looking at those infectious outcomes in those patients converted to belatacept, specifically looking at those infections leading to hospitalization. Secondary objectives, we looked at the impact on renal function post-conversion to belatacept, as well as a variety of complications that might be associated with belatacept therapy. Next slide. Inclusion and exclusion criteria. So again, any kidney transplant recipient greater than or equal to 60 years old at the time of transplant or conversion was included. Exclusion, we excluded any multi-organ transplant recipients and any patients with a history of previous organ transplant other than kidney. Next slide. Moving into discussion on my results. Next slide. So looking at our donor baseline characteristics, we can see overall no significant differences. Most of our donors were deceased donors. Next slide. Looking at recipient baseline characteristics overall, you can see, again, age was 70.5 years for the mean. There was a significant difference in the proportion of males represented in each cohort, with an overwhelming majority of males in our belatacept cohort compared to our tacrolimus cohort. Most of these patients were African American, and ESRD was primarily due to diabetes and hypertension. Next slide. Furthermore, looking at our CMV and EBV serologies at the time of conversion, no significant differences. I do want to point out history of DGF. So there was a significant difference here where more patients in the belatacept cohort had a history of DGF, which makes sense if we're converting these patients for promotion of like renal recovery. Next slide. Looking at induction immunosuppression that these patients received across the tacrolimus and belatacept cohorts, the majority of these patients received anti-thymocyte globulin for induction. Next slide. Looking specifically at those patients converted to belatacept, so the mean age that these patients were converted was 68.3 years old. Reason for conversion, so again, about half of these patients were converted for that promotion of renal recovery. Some patients converted for CNI nephrotoxicity or neurotoxicity. A small number of patients who had that history of ABMR. Time from belatacept conversion from transplant was a mean of about 153 days. Time from belatacept initiation to CNI discontinuation was about 62 days. So again, kind of within that time frame of the first 4 to 6 belatacept doses. Of the 33 patients converted, 10 of those patients discontinued belatacept. We can say a handful of these patients discontinued for the primary reason being infection, and then the other 7 kind of fell into this other category. But looking further into this data, a lot of these patients were those patients who were deemed to have like primary allograft failure and were either having some adjustments in their regimen or being relisted and whatnot. Next slide. Looking at our primary outcome across the board, you can see that there's no statistical significant difference in bacterial, CMV, BK, fungal, or PGP infections. Slighter number of patients on belatacept who had CMV, and 1 patient had PGP compared to no patients in the tacrolimus cohort, but then again, nothing alarming that stands out. Next slide. Looking at our secondary outcomes, for the key result from this slide that I want to point out is looking at our graft loss. So 8 patients in the belatacept cohort compared to 0 in the tacrolimus cohort experienced graft loss, which was found to be statistically significant. But you can see for rejection, malignancy, and death, a greater number of patients experienced those who were converted to belatacept as well, which was not statistically significant. Next slide. Looking specifically at belatacept dosing and renal function, so this was something we looked at 0, 3, 6, 9, and 12 months. You can see for the belatacept dose started a tad bit higher than that 5 mg per kg, but you can see throughout that time frame, really sticking close to that 5 mg per kg dosing. If we look at eGFR trends over the months, looking at belatacept compared to tacrolimus, this was something interesting that I found. So those patients with tacrolimus started off with a reduced ejection fraction, eGFR compared to our belatacept patients, but they ultimately had that renal recovery, and we can see that sustained anywhere from like 40s to the 50s range. But then for our patients in belatacept, they started off with an eGFR about 21, but those patients kind of never really recovered but had stable preserved renal function anywhere from like 30s for their eGFR. Next slide. So summary of my results, primary outcome, although again, not statistically significant, patients on belatacept had a higher incidence of CMV infection and 1 patient had PJP infection. Similar incidence of all the other infections we looked at. For secondary outcomes, more elderly patients converted to belatacept experienced graft loss, and those converted to belatacept had higher rates of rejection, malignancy, and mortality, although not statistically significant. Next slide. Some limitations of our study, again, single center retrospective, relatively small cohort of just greater than 60 patients. Tacrolimus cohort selection was done through a random number generator just due to time and resources. We didn't pursue matching. Some incomplete documentation with the patient's charts, and then only examining culture and laboratory data for infections, as well as only capturing those leading to hospitalization. So again, not capturing potentially all infections that could have occurred. Next slide. So in conclusion, this study, we found no difference in the rates of infection between those maintained on tacrolimus versus converted to belatacept. However, continued assessment of elderly kidney transplant recipients converted to belatacept is necessary to minimize infection risks while preserving allograft function, hopefully potentially evaluating this in a larger cohort to seeing if there is that true difference or increased risk of infection. Next slide. I'd like to acknowledge my advisors and our physician champion for all their help and work on this project. Next slide. That's all I have.
Thank you so much, Nicholas. Again, if you have any questions on the presentation, please feel free to put your questions in the question and answer feature on Zoom, and we will get to those at the end. And with that, we will move on to our next presenter.
Hi, everyone. Can you hear me okay?
Yes, I can hear you.
Okay, perfect. Well, hi, I'm Adriana. I'm one of the PGY2 transplant residents at University Health in San Antonio, Texas. And today I'm also going to be presenting my research project on belatacept, specifically its use in obese compared to non-obese kidney transplant recipients. Next slide, please. Before I begin, I have no disclosures or relationships related to the presentation. Next slide, thank you. Some objectives by the end of this presentation, you should be able to understand how obesity interacts or plays a role in the pharmacokinetics of belatacept in a kidney transplant recipient, understand the importance of evaluating belatacept's use in this population by talking about some of the potential clinical implications, specifically, again, in obese patients, and then we'll end with our evaluation at University Health within this patient cohort. Next slide, please. So for starters, what is belatacept? We're all very familiar with belatacept at this point, but essentially it's a co-stimulation inhibitor that's predominantly used for CNI minimization, mainly for the renal preservation. It also has the potential to limit the amount of metabolic adverse effects like diabetes and things like that that are associated with calcineurin inhibitors, which are very important in the obese population where these patients could already be at higher baseline risk. Another area where belatacept can be used is for reduction in donor-specific antibodies, which we know are the driving force of antibody-mediated rejection. With all medication therapies, there are, of course, risks associated with it, specifically with belatacept, how it was initially studied. It had shown higher incidence of early acute rejection within that first year post-transplant. Next slide. So there are two dosing strategies with belatacept, the first one being de novo belatacept, and then now, secondly, what has pretty much become the standard of care, which is belatacept conversion. It was with de novo belatacept use, how it was designed and predominantly studied, that was associated with increased risks of one-year rejection. De novo belatacept being the initiation of belatacept on post-op day 0, right when your patient comes out of the OR, totally in replace of tacrolimus. Now with belatacept conversion, while it's not a true conversion, but more so a transition over to reduce the overall exposure to calcineurin inhibitors, studies have found that some calcineurin inhibitors better than no calcineurin inhibitor, reducing that risk of one-year rejection, but ultimately the goal of belatacept conversion is to come off of our calcineurin inhibitor entirely. Next slide. Now, since we're pharmacists, we are very well versed in package labeling, or at least we should be. And within the belatacept package insert, there is a statement that says that pharmacokinetic studies have shown that there's an increased drug clearance of belatacept in patients with increasing body weight. Increased clearance of belatacept therefore means reduced immunosuppression and thus a potential increase in the risk of rejection for our patient. Next slide. There are two studies that evaluate belatacept's use in obese kidney transplant recipients. This first one by Likvar and colleagues evaluated belatacept conversion and stratified patients based on their BMI and concluded that patients with a higher BMI had statistically higher rates of rejection as compared to the non-obese or as compared to the BMI cohort less than 35. Some limitations of this study was that this study was non-peer reviewed. It really didn't follow classic BMI stratification as what we're used to seeing, and of course it's limited by its small sample size of 38 kidney transplant recipients. Next slide. This next study was a post-hoc analysis of the very well-known benefit studies that evaluated patients receiving de novo belatacept compared to cyclosporin. Patients were also stratified by BMI, and not only did the authors of this study conclude that there were higher rates of rejection in patients with a BMI of 30 or greater, but that incidence of rejection was also more severe. Limitations of this study was evaluation or comparison of de novo belatacept use and cyclosporin, both of which are not necessarily the standard of care as compared to belatacept conversion and tacrolimus. And while the BMI stratification in this study is a little more classic, majority of patients in this cohort did not meet obesity criteria or had a BMI that was less than 30. Next slide. So overall, with this research study, our clinical question was to evaluate the impacts that obesity may have on safety and effectiveness of belatacept conversion specifically as compared to non-obese kidney transplant recipients. Next slide. This, of course, was a single center retrospective observational cohort that we pulled patients from July of 2020 to October of 2024 to allow an adequate amount of follow-up time. And we stratified patients based on a BMI of 30 or greater and that of less than 30. Next slide. We included adult kidney transplant recipients that were converted from tacrolimus-based immunosuppression to belatacept. We excluded patients if they had a history of a multi-organ transplant, if there was less than 3-month follow-up data available in the electronic health record, and we also excluded patients who missed more than 1 belatacept infusion without a clinical indication. Next slide. All patients were evaluated for effectiveness, safety, and other exploratory outcomes. For effectiveness, we were predominantly looking at biopsy-proven acute rejection, and then what we define as empiric rejection treatment, which was the initiation of either lymphocyte-depleting therapies, other biologic therapies like IVIG, or systemic steroids. Safety, we evaluated both patient and death-censored graft survival, viral infections, as well as overall infection rate and the incidence of PTLD. And because belatacept's claim to fame is for renal preservation, we did evaluate patients' renal function while they were initiated on belatacept. Next slide. At University Health, this is what our belatacept conversion protocol looks like. Patients in their reduction belatacept phase are typically started on 5 mg per kilo and then are continued on a 5 mg per kilo maintenance phase dosing. Patients, however, can get a higher belatacept induction dose of 10 mg per kilo if they need rapid discontinuation of their tacrolimus therapy, like for the instance, if they have TMA or if they are early post-transplant. Within 2 months post-transplant, they can also get the higher 10 mg per kg dose. Tacrolimus is continued upon belatacept initiation, and our trough goal is decreased to 50% at the second dose of belatacept and is continued at that goal for 12 months. Next slide. Majority of our patients were initiated on belatacept for CNI minimization, mainly for renal preservation purposes. Next slide. Within our cohort, there was a pretty even split of patients who were male. Overall, patients were predominantly middle-aged and identified as Hispanic or Latino. For obvious reasons, there were statistically significant differences in their weight and BMI. However, when we look at BMI classification specifically in our obese cohort, majority of patients fell into that class 1 obesity category, followed by class 2 obesity and greater. Next slide. Overall, our patient cohort we considered as low immunologic risk when looking at their CPRA and looking at the low overall history of a positive T or B cell crossmatch, history of prior rejection, or history of a prior transplant. Of course, all patients are evaluated for their CMV serostatus, both donor and recipient. So our majority of our cohort was considered moderate risk, so recipient positive for CMV. Next slide. Majority of the kidney transplant patients received Thymo, which is not uncommon at our center. If you look at the tacrolimus trough, patients were overall at 9 nanograms per milliliter, which was appropriate for their time post-transplant, being around 3 months. When belatacept was initiated, majority of patients were started on a 5 mg per kilo belatacept initial dose, and tacrolimus was appropriately discontinued at approximately 12 months post-belatacept initiation, so appropriately following our protocol. And then at the time of data collection, the median duration of belatacept for patients was roughly 10 months. Next slide. When looking at our rejection outcomes, there was overall at 3 and 6 months a low incidence of biopsy-proven acute rejection and what we considered empiric rejection treatment. However, you can see that things were numerically higher in the obese cohort, specifically at 6 months in the empiric rejection treatment outcome. Next slide. For safety outcomes, there was great overall patient and graft survival. There was a low incidence of CMV and low incidence of BK. There's still around like 18% of patients with CMV at 3 months, a little lower at 6 months. But again, similar to other studies, and no patient within our cohort experienced PTLD. Next slide. For renal function, overall, patients who were initiated on belatacept experienced improvements in their renal function. Something I did just want to highlight is that patients who were non-obese experienced improvements in their renal function earlier, as soon as month 1 after being initiated on belatacept, whereas patients in the obese cohort, while they did overall experience improvements in their renal function, you don't see those improvements for patients who are obese until month 3. Next slide. When looking at overall infection rate, 32% of patients experienced a positive culture or PCR while being initiated on belatacept, with majority of those infections or PCRs being viral. All of these viral infections were in fact CMV. Next slide. 4 patients discontinued belatacept therapy at 6 months. No statistical significance between the non-obese and obese patients, but predominantly patients were discontinued off their belatacept for infection. Next slide. In conclusion, there was similar safety and effectiveness in what we considered a low immunologic risk cohort of obese compared to non-obese kidney transplant recipients, with an overall improvement in renal function as are observed post-belatacept conversion. Next slide. With all studies, they're not without their limitations, but starting with some of the strengths of this study is that this is a very large sample size and includes a good representation of obese kidney transplant recipients, and our inclusion of tacrolimus-based immunosuppression as compared to other studies, including cyclosporin. Limitations of this study include, while it is one of the larger sample sizes, there is an increased risk of a type 2 error, specifically at 6 months, because of the number of patients that were able to follow or reach 6 months for belatacept duration. And of course, our outcomes were not assessed at 12 months, which 12 months is the critical year post-transplant, and where you typically see that increased risk of rejection with belatacept in previous studies. Next slide. In order to strengthen the results of our study, we would love to increase our sample size and, of course, try and get more number of patients at 12 months post-conversion so we can see outcomes, more long-term outcomes. Because belatacept is known for reduction in DSAs, we would like to do more analysis on the patient's DMA trends post-belatacept conversion using MFIs, and of course comparison of dosing strategies, since at our center patients can either be initiated on 5 or 10 mg per kilo, and seeing if that plays any role in patients specifically who are obese. Next slide. I'd like to thank all of my mentors and colleagues for helping me with this presentation. Next slide. And I welcome any questions.
Thank you so much for that great presentation. We will save all of our questions for the end, as mentioned, use the question and answer function, and we will discuss those towards the end of the presentations. With that, we will move on to our next section, which is going to be belatacept and lung transplant specifically, and we'll start with our presenter for this section.
Hello everyone, just want to make sure you can hear me.
I can hear you.
Okay. Well, my name is Mabi Ahmadi. I am a PGY2 transplant resident at University of Chicago Medical Center, and today I will discuss evaluation of donor-specific antibody development in lung transplant recipients who were maintained on belatacept. Next slide, please. Just to disclose, I do not have any financial interest to disclose, and I will discuss off-label use of belatacept in lung transplant recipients. Next slide, please. Like we have received a lot of background information. So what is relevant to our lung transplant patient? We know that belatacept is a T-cell co-stimulation blocker approved for rejection prophylaxis in renal transplant recipients. The studies in renal transplant show belatacept actually reduced DSA production compared to cyclosporine. And in lung transplant recipients, they are at higher risk for developing DSA, which are associated with bronchiolitis obliterans syndrome. Next slide, please. So the objective of my study is to evaluate the development of de novo and persistent DSAs in lung transplant recipients maintained on belatacept as part of their immunosuppression regimen. Next slide, please. This was a single-center retrospective cohort study included adult lung transplant recipient from 2017 to 2022. We included adult patient with an EBV IgG positive who had at least one DSA measurement during the belatacept treatment. We excluded patients who received belatacept for less than 180 days. Also, patients who received belatacept for desensitization, and if they were a recipient of multi-organ transplant. Next slide. So the primary outcome was development of de novo DSA or persistence of pre-existing DSA, and the secondary outcomes include incidence of biopsy, proven rejection or graft failure, defined as death, retransplantation, or relisting for transplant. Next slide, please. So before going over the result of the study, I wanted to review our immunosuppression regimen for this population. The belatacept, we used two different strategies to switch patient to belatacept. Either they were started on first fast conversion, meaning we started them on 5 to 10 milligram per kilogram on day 0, 4, 14, 28, and then we switched to Q every 28 days. And we reduced tacrolimus goal with the first belatacept dose. And the other strategy was to slow convert this patient to belatacept, starting on 5 to 10 milligram per kilogram on weeks 0, 2, 4, 6, 8, and then every 4 weeks, and beginning reducing tacrolimus on week 2 and target new goal by week 4. If the patient were recipients of lung less than a year, we started them on 10 milligram per kilogram. And if they were beyond 1 year post-transplant, we started belatacept at 5 milligram per kilogram. We reduced our tacrolimus goal to a goal of 1.5 to 3. And we continued mycophenolate on this patient. And if they were on azathioprine, if we were able, we switched them to mycophenolate, and we continued the prednisone for this patient. Next slide, please. Now let's look at the result of this study. Looking at baseline characteristic, the median age of our patient at transplant was 59 years old. Majority of them, 77% were male. Majority of patients, 54% were Caucasian, with a good percent of African American patient, 31% of our population, following by Hispanic population. The native organ failure reason mostly was interstitial lung disease. The induction agent mostly was basiliximab. We used TIMO for 2 of our patients, and 1 of our patients did not receive any induction. And the immunosuppression regimen at time of belatacept start mostly include tacrolimus, mycophenolate, and corticosteroids. And at the time from transplant to start of belatacept was a median of 12 months. We started patient as soon as 2 weeks post-transplant to 23 months post-transplant. Majority of patients were started on belatacept a year after a transplant. However, we had patients we immediately started on belatacept after transplant. That was 31% of our patients. Next slide, please. Assessed 45 patients for eligibility. I excluded 19 of those patients because they received belatacept less than 6 months. And the majority of patients were started on belatacept for the renal sparing indication. However, one of the patients also had DSA at the start of belatacept. That cohort included 26 patients. We followed this patient for 28 months, and discontinuation rate of belatacept was 46%. Next slide, please. Looking at reason for belatacept discontinuation, so out of 12 patients who were discontinued, 5 of those patients did not have any renal recovery, so there was no point to continue belatacept. That was 42% of our patients. 2 patients, because of the infection, we discontinued belatacept. There were 2 patients who had respiratory dysfunction and decline in lung function, so belatacept was discontinued. 2 patients did the insurance did not cover, so we had to discontinue belatacept. And 1 patient did not want to receive infusion anymore, so requested to switch back to tacrolimus. Next slide, please. The primary outcome, which was development of de novo DSA or persistence of the pre-existing DSA, was we had 5 patients that had DSA before the start of belatacept. However, it was resolved by treatment before the start of belatacept. No patient developed new DSA during belatacept treatment, and only 1 patient had DSA at start of belatacept, which DSA strength, as you can see in this curve, decreased during belatacept treatment and stayed on the less than 2,000 with an MFI less than 2,000. Next slide, please. For secondary outcome, looking at biopsy-proven rejection, I had 1 patient that had a rejection of A2B0, which was successfully treated with high-dose steroid. Time to acute cellular rejection was a month and a half post the start of belatacept. This patient was the patient who had already pre-existing DSA, and this patient also had episodes of rejection before the start of belatacept. The second patient had an A1B0 rejection, which did not require treatment, and this happened like almost a year after start of belatacept. In terms of graft failure, so I had 4 patients that were passed away while they were on belatacept. No other patients were retransplanted or relisted. Median time to death from belatacept start was almost a year, and 2 patients were already on hospice due to declining respiratory function, and 2 other patients actually passed away because of complication of infection. Next slide, please. So looking at limitation of this study, it was a retrospective design without a comparator group, which limited to conclude any to make any conclusion from this study. Most patients initiated belatacept for renal sparing purposes rather than due to baseline DSA present. Like I mentioned, only 1 patient had DSA at baseline. And also we excluded patients who were receiving belatacept less than 6 months. So that could have also impacted assessment of certain outcomes such as mortality. Next slide, please. In conclusion, in this study, belatacept was mostly used as a renal-sparing immunosuppressant in lung transplant recipients. No de novo DSA developed during belatacept therapy. Patients with pre-existing DSA experienced favorable outcome, including a reduction in DSA strength. Rates of rejection and infection remained within acceptable limits. And this finding suggests that belatacept may be a promising alternative agent in lung transplant population. Next slide, please. With that, I would like to thank you, my mentors, to help me to complete this project. Next slide, please. And thank you all for your attention. And please feel free to ask your question at the end of session. Thank you.
Thank you so much for your great presentation. Again, as she mentioned, use the question and answer feature, and we will move on to our next presenter.
Hello, everyone. My name is Gallup. Can you hear me okay?
Yep, I can hear you.
All right. My name is Gallup. I'm one of the PGY2 transplant residents at the University of Pittsburgh Medical Center. Today, I'll be presenting my retrospective evaluation of belatacept as salvage immunosuppression in lung transplant recipients. Next slide, please. So as we all know, calcineurin inhibitors have been the cornerstone of immunosuppression in solid organ transplant. And over the past few decades, they've significantly improved patient outcomes and transplant outcomes. However, their long-term use is associated with substantial toxicities, including nephrotoxicity, metabolic disorders, and urologic complications, all of which can negatively impact both morbidity and mortality in lung transplant and in transplant recipients. Next slide, please. So as mentioned in the previous presentations, belatacept is a relatively newer immunosuppressive agent. It is a fusion protein made up of the Fc fragment of the human IgG linked to the extracellular domain of the CTLA4. Next slide, please. Belatacept acts by blocking the T-cell co-stimulation, therefore specifically binding to CD80 and CD86 receptors on the antigen-presenting cell, which is unique for belatacept, and therefore preventing the activation of the T-cell. Next slide, please. Now, belatacept is FDA approved for the prevention of graft rejection in adult renal transplant recipients. At our institution at UPMC, belatacept is mainly used as a rescue therapy, primarily for patients who cannot really tolerate CNIs. That's the other slide, sorry. This approach also applies to lung transplant recipients, especially those who are unable to tolerate higher immunosuppression goals. However, despite this, there's a lot of concern remaining about the safety of belatacept, specifically in lung transplant patients, due to the lack of robust evidence, along with some potential risk of increased rejections or increased infections. Next slide, please. And therefore, the objective of the study was to evaluate the long-term efficacy and safety of belatacept-containing regimens in lung transplant recipients. Next slide, please. This was a retrospective study conducted at UPMC. We included adult transplant recipients who were started on belatacept between 2012 and December 31st, 2024. And it's important to note that patients were either transitioned fully to a belatacept-based regimen or had belatacept added to their existing CNI regimen. Next slide, please. We collected data based on patient demographics, including age, sex, transplant indication, and transplant type. We also evaluated the immunosuppressive regimen both before and after transplant, in addition to the induction type of induction used at the time of transplant. We also looked at graft survival and defined failure as death or lung retransplantation. Regarding renal function, we assessed serum creatinine and the need for dialysis. We also looked at recorded biopsy-proven cases of acute cellular rejection and antibody-mediated rejection. We also tracked the development of chronic rejection and finally documented all positive cultures following 1 year after belatacept initiation. Next slide, please. A total of 72 patients were included in the study with a median age of 58. About 40% of these patients were female, and the majority were identified as white or Caucasian. Approximately 90% of these patients underwent double lung transplant. And when looking at the induction therapies, 55% of these received basiliximab, with the remaining 45% receiving a type of depleting agent, most commonly alemtuzumab, which is around 42% of the cases, followed by antithymocyte globulin. Next slide, please. After belatacept initiation, patients had a median time on belatacept therapy of around 2.5 years. The median time for belatacept initiation following transplant was 1.1 years. And most patients, around 73% of these patients, were transitioned to the belatacept using the high loading dose strategy, which started with 10 milligrams per kilogram, then transitioned to 5 milligrams per kilograms every 4 weeks. Next slide, please. The leading indication for lung transplant was interstitial lung disease, which accounted to nearly half of the patients. This was followed by COPD and then cystic fibrosis. The remaining 12% of the patients included less commonly indicated indications such as pulmonary arterial hypertension and inhalation-related toxicities. Next slide, please. The primary reason for starting belatacept mainly included renal toxicities as a renal sparing agent, but this was also followed by a lot of hematologic toxicities and then neurologic toxicities. A smaller portion of the patients, around 6%, were started on belatacept due to multiple rejections, and the remaining 10% had other indications that I was not able to include or did not fall into the previous categories. Next slide, please. Now, before belatacept, CNIs were used in 97% of the patients. This dropped to 40% after the initiation of belatacept. Similarly, the use of cell cycle inhibitors such as azathioprine or mycophenolate declined from 79% to 65% after belatacept initiation. And also the use of mTOR inhibitors also decreased from 38% to 22% after belatacept initiation. It's also important to know that all of these patients remain on some form of steroid before and after belatacept initiation. Next slide, please. When looking at lung function, we can see lung function remained relatively stable throughout the study. FVC showed a slight increase after 5 years or the last follow-up, while FEV1 showed a slight decrease after 5 years or the last follow-up. When looking at the renal function, at the time of belatacept initiation, 22% of the patients were on renal replacement therapy. This figure increased to 38% after 5 years or the last follow-up. But it's also important to note that 6 out of these 16 patients who were initially on dialysis were able to come off renal replacement therapy after belatacept initiation. Next slide, please. Following belatacept initiation, 42% of the patients had at least one documented acute cellular rejection of grade A1 or higher. Antibody-mediated rejection was treated in 8% of these patients after belatacept initiation. And around 46% of the patients either had a chronic rejection at the time of belatacept initiation or developed it afterwards because it was a little bit hard to determine the exact time of diagnosis. Next slide, please. Now, when evaluating infection risks and infection rates, 1 year after belatacept initiation, we can see that CMV and EBV viremia were both detected approximately 15 to 19% respectively. Culture-positive urinary tract infections and culture-positive bloodstream infections were observed in about 18% of the patients. And finally, culture-positive respiratory infections, such as positive BAL cultures and positive sputum cultures, were identified or documented at least in 44% of the patients. Next slide, please. When looking at the 5-year Kaplan-Meier survival curve, we can see that the survival after belatacept initiation was 4.13 years. Next slide, please. And when we compared the survival between patients who remained on some form of CNI after initiation of belatacept, we found no statistical difference between patients who were on a CNI-free regimen and patients who were both on a CNI and a belatacept regimen. Next slide, please. So in summary, belatacept-based regimens were associated with a relatively stable lung function based on the study over time, with only minimal changes in FVC and FEV1. When considering renal outcomes, the outcomes were a little bit mixed. So some patients were able to get off dialysis, but other patients stayed on dialysis and the risk increased, or the number of patients on renal replacement therapy increased over time. When looking at the survival curves, the survival was a little bit consistent with average post-lung transplant survival rates, with the average median survival of 4.13 years after belatacept initiation. And these results suggest that belatacept may be a viable salvage option in select lung transplant recipients. But larger prospective studies, because the main limitation of the study is its retrospective design, so larger prospective studies are needed to better determine the optimal timing for its use or initiation of belatacept in order to maximize renal benefits and minimize rejection risks. Next slide, please. I'd like to thank all of my mentors and everyone who helped me. And next slide, please. And I'll answer any questions at the end. Thank you.
Thank you so much for your presentation on using belatacept long-term in lungs. And so with that, we will go to our last presentation, which is just in the category specifically of lung transplant. So here's our next speaker.
Thanks, Kelsey. Can you hear me?
Yes.
Okay. Hi, everyone. My name is Jane Kim. I'm the PGY2 solid organ transplant pharmacy resident at Tampa General Hospital. I'm going to be sharing a little bit about my research project entitled Trendy Surveillance, Utilization of Donor-Derived Cell-Free DNA Trends for Acute Rejection Surveillance in Lung Transplant Recipients. Next slide, please. I nor the rest of my research team have any disclosures. Next slide, please. And the objective of today's presentation is to describe the clinical utility of donor-derived cell-free DNA trends for acute rejection surveillance in lung transplant recipients. Next slide, please. Thank you. A little bit of background. Transbronchial biopsies, or TBBX, or bronchs, are the gold standard for the diagnosis of acute rejection after lung transplantation. However, we know that transbronchial biopsies are complicated and they have a lot of limitations. So some of those include subject to sampling errors, inter-observer variability. It's invasive procedure, so there's complications like hemorrhage and pneumothorax, and it's also costly. Next slide, please. So donor-derived cell-free DNA is fragmented DNA that gets continuously released by donor cells into the bloodstream during allograft rejection or injury. And so it's thought that an increase in donor-derived cell-free DNA can indicate allograft injury. A lot of the studies currently that are published seek to determine a threshold that might most accurately detect acute rejection. So this might range between like 0.8% to 1%. But we hypothesize that trending donor-derived cell-free DNA as a continuous variable would be less subject to some of the heterogeneity that we might see between baseline characteristics and thus provide greater utility. Next slide, please. So the purpose of our study was to assess the correlation between donor-derived cell-free DNA trends and incidence of acute rejection in lung transplant recipients. Next slide, please. A little bit about our study design. This was a single center IRB approved retrospective cohort analysis conducted here at Tampa General Hospital. We included all the donor-derived cell-free DNA levels between 2021 and September, which is when we incorporated this into our protocols, up until IRB approval, so July of 2024. We categorize all of these donor-derived cell-free DNA levels based on its paired transbronchial biopsy, which was within the 2 weeks post the level. According to ISHLT definition and diagnostic criteria, so categorized into either stable, ACR, subclinical AMR, and AMR. Next slide, please. So we included all adult lung transplant recipients who were 18 years and older, and we excluded patients who were multi-organ recipients or retransplanted if they had died within 30 days post-transplant, if they were transplanted outside of TGH or Tampa General Hospital, and then if they had less than 3 donor-derived cell-free DNA samples to a corresponding transbronchial biopsy. Next slide, please. Similar statistical analysis. So we use descriptive statistics to analyze demographics, median and IQR to analyze non-parametric data, mean and standard deviation to analyze parametric data. a Wilcoxon sign rank test to test the mean values of two dependent variables, Friedman ANOVA test to analyze non-parametric repeated measures, Spearman rank correlation to assess the relationship between donor-derived cell-free DNA and FEV1, and then ROC curve to represent the performance of a binary classification model for a classification threshold. Next slide, please. These were our outcomes of interest. So our primary outcome, we were looking at evaluating the trend of donor-derived cell-free DNA before acute rejection, which we label as pre-levels 1 to 3, and after acute rejection treatment, which we label as post-levels 4 to 6. Some of our secondary outcomes included assessing the change of FEV1 before acute rejection and after acute rejection treatment, and then lastly, determine the correlation between donor-derived cell-free DNA and the change in FEV1. Next slide, please. And so these are some of our results. Next slide, please. These are our study cohorts. So we had 70 patients included. There were no repeated patients between cohorts, within a cohort, but they can be repeated between cohorts. So we had 66 patients in the stable group, 7 of which who received steroids. ACR group, we had 46 patients, 35 patients had received steroids. We did have 1 patient who was steroid refractory who received thymo, and 10 patients did not receive treatment. And then we had 1 patient in the subclinical AMR group who received PLEX and IVIG, and then AMR patient 1 who received PLEX, IVIG, and carfilzomib. Next slide. These are some of our baseline demographics. So our average patient was a 60-year-old male, white male who was a bilateral transplant recipient, primarily for IPF. Next slide. These are some of our clinical characteristics. So of note, the donor-derived cell-free DNA at the time of transbronchial biopsy was the highest in the AMR group, so 0.78, followed by the ACR group, 0.76, followed by stable, 0.71, and then our subclinical AMR patient who had AlloSure of 0.43%. FEV1 was highest in the stable group and the AMR group, followed by the ACR group, which was 1.98, followed by the subclinical AMR patient with 1.38. We did have some patients who had pre-existing DSA, so about 6% of our entire cohort. There were 3 in the stable group, 4 in the ACR group, and none in the AMR cohorts. Next slide. So this is our primary outcome. It might be a little bit hard to see, but this was looking at the trend of donor-derived cell-free DNA before acute rejection and after acute rejection treatment. So if you see in pre-level 1, it was 0.68 median. Pre-level 2, which was 0.48, it increased by more than 50% at the time of biopsy-proven acute rejection, which you can see denoted as a star. So pre-level 3 is when they have biopsy-proven acute rejection, and it increased from prior level of pre-level 2 by more than 50%. Interestingly, after ACR treatment, this level subsequently decreases to even lower levels than their baseline. So post level 4, 5, and 6, you see 0.49, 0.4, 0.3, 0.38, which is lower than what they started with 0.68. Next slide, please. This is looking at their FEV1 before acute rejection and after acute rejection treatment. So in ACR and the subclinical AMR group, they did have improvement of their FEV1 after ACR treatment. The AMR patient did not show improvement, but just keeping in mind that there was only 1 patient in this cohort, the subsequent FEV1s that were measured afterwards were increased. Next slide, please. And this is our last outcome. Secondary outcome was looking at the correlation between donor-derived cell-free DNA and FEV1. So we see a negative correlation. An increase in donor-derived cell-free DNA was associated with a decrease in FEV1. This did have a row of negative 0.18, but it was not found to be statistically significant. Next slide, please. And so in conclusion, trending donor-derived cell-free DNA levels as a continuous variable rather than comparing against a fixed and predefined threshold may be a useful strategy in detecting and predicting acute rejection, as well as on the flip side, assessing therapeutic response following acute rejection treatment. Utilization of donor-derived cell-free DNA trends may have a role in non-invasive rejection monitoring, minimizing the need for post-acute rejection follow-up bronchs, and thereby also reducing some of the bronch-associated complications. Next slide, please. I'd like to acknowledge and thank all of my preceptors and my whole research team and all of their help. Next slide, please. That concludes my presentation. Feel free to leave any questions in the chat.
Thank you so much. Now we'll just move on to the question and answer portion of these presentations. If anybody has any questions for our presenters, feel free to drop those in the chat or use the question and answer feature that is located on Zoom. And we'll stay around for a couple minutes to answer any questions. Otherwise, we will be sending out an email later on this week that is going to give you information on how to obtain CE credit from these presentations. I guess I'll ask a question while we wait to see if anybody else comes up with some questions. So for the presentation on belatacept as salvage therapy, for your rejection outcomes, was that similar to what you see at your center related to CNI therapy, or was it any different? Or did you even evaluate that?
So I'm not sure exactly what the percentage of rejections for the CNI group is, but we are currently working on matching these patients to a CNI-based regimens, and we're almost done with the statistical analysis and everything, but I'll have to double check for that.
Awesome.
Sorry.
Thanks. Yeah, that was
I can
great.
email you if I have the numbers.
Awesome. That was a great presentation. So thank you.
Yep, thank you.
Of course. And I'll ask another question and then we can just end so that everybody can get on with their day. But Jean, for your study, did your team evaluate if any of the patients that you were getting donor-derived cell-free DNA on, were they in an acute infection phase or anything like that when you were ending up getting those lab values?
Yeah, that's a really good question. We decided to keep it purely on bronchoscopy results. I know that there's a lot of impact of concomitant infections. We decided not to look at that. I kept a note of it on the side, but we didn't include it in our analysis. But we did make sure our stable cohort were also non-infectious.
Thank you.
Mhm.
All right. Looks like we have a question. So this is for Nick. Why do you think that the tacrolimus group ended up with numerically better eGFR versus the belatacept group by the end of your follow-up time? How did you characterize eGFR for patients with graft failure?
Thank you for that question. And that was something, still kind of finalizing the data, but that was an interesting point or like outcome that we saw because we would expect with like the belatacept group to see maybe like a starker increase in their EGFR renal function. But I think just looking at the patients, especially these elderly kidney transplant recipient patients who were like converted, just had like prolonged DGF or we were just, I guess, quote unquote, using this as salvage therapy just to preserve whatever renal function they had left. And for the classification of like those with like renal failure, this was, I guess, could say was like another limitation. It was just like going based on like chart review or provider discretion on like at what point in their follow-up were we actually gonna like diagnose or like confirm this was graft failure. So again, there was like some variability in that, but just an interesting point that we saw. And so kind of on the back end, so looking at like maintenance immunosuppression for both cohorts and any like changes or differences there that might impact that outcome as well.
Thank you for answering that question. I'll give it like 1 more minute to see if anybody else has any questions, and then we will adjourn for the day. All right. I want to thank everybody again for attending and all of the residents for participating in this webinar. This was recorded and will be posted on the YouTube channel after the ending of the CE period to claim credit. Again, that will be sent out to you from me over the next couple days. So be checking your email for how to claim that. And we hope to see you at our last session of the PGY2 research webinar. It will be held at the same time next Tuesday, the 20th. Thank you, everybody, for coming and spending your afternoon with us, and have a good evening.
Thank you.
Thank you.